Yep.
Yeah, I saw patients today, and we still have surgery scheduled for those who need it. So
wow.
Urgent cases only. So.
Well, we're looking forward to seeing some of your cases here. So we're going to have a Rishi Singh will present first, and we'll have a spot for some quick discussions amongst yourselves. We'll then go to Dr. Baumel, and there'll be a spot for us to ask questions again, and then the audience. If the audience could go ahead and put questions in the questions and answer section, we'll go ahead and answer them when we get to the end there. And I don't know, you guys haven't quite found the barber that I found to take care of the COVID haircut. So
is that vacuum cleaner that you attached to a
yeah, no. It was my wife took care of me. We're good to go. So
that's great.
Without further ado, I'm going to go ahead and turn my cameras off here, and we'll just have Dr. Singh. We'll have your presentation first. Thank you, everybody. And again, if you have questions, please put them in the question and answer section.
Of retinal fluid and neovascular AMD. Here are my financial disclosures for this presentation. So we'll start off with a case for our discussion. This is an 83-year-old Caucasian female who presented with visual acuity of 20/60 in this eye. And she presents with an OCT, which has both intraretinal fluid, sub-RPE fluid, and subretinal fluid. And the questions, I think, when you look at a patient like this from a clinical standpoint is, what would you tell this patient about their outcomes based upon this initial OCT? How does fluid, or these compartments of fluid, interface or change your treatment decisions based upon your drug or your aggressiveness with the regimen? And finally, how can we use some of our existing modalities in clinic that we have, imaging modalities, to really determine how these patients are responding to treatment? So let's talk about all of these a little bit more in detail. And so I showed you that OCT, and here you can see labeled nicely is those individual compartments of both intraretinal fluid, subretinal fluid, and sub-RP fluid. And so we've learned from more recent large randomized clinical studies that each of these compartments have a very, very different function and different outcomes with regards to their response to treatment as well as their prognosis for vision. So let's explore that a little bit more in detail in the next few slides. So let's start off with looking at intraretinal fluid. Intraretinal fluid actually may be a poor predictor of final visual outcome. It's a hallmark in type 2 and type 3 CNV lesions. It commonly occurs with a PED, but not with subretinal fluid. And usually it's associated with what we consider an aggressive phenotype with neovascularization, and is potentially responsible for poor visual acuity responses seen in the neovascular AMD studies. And probably the first evidence we got from any trial was around in the VIEW trials, where we learned that patients with early persistent intraretinal fluid had worse visual outcomes than those without persistent retinal fluid as early as 24 weeks. Within that very, very short time frame, you could see almost a 2-letter differential in those who had persistent intraretinal fluid in the first 3 months of treatment, in fact, and those responses to the final visual outcome showing a slight reduction. We also learned that the presence of intraretinal fluid also had some ability to affect visual function scores. And we always used, obviously, visual acuity as our marker for activity, but really when you talk to patients, they have a lot of different impact on their activities of daily living. And so looking at this, we looked at actually the study of visual functional questionnaire responses and found both role difficulties in driving were affected significantly by the presence of persistent intraretinal fluid. Looking at the CAT study, which evaluated both Avastin and Lucentis for the treatment of neovascular AMD, they also found the same result, which is at year 5, those who had persistent intraretinal fluid almost had a 12-letter differential over those patients who did not have intraretinal fluid at that 5-year time point. So pretty impressive to see, again, that intraretinal fluid, that presence of that intraretinal fluid really had a poor prognosticator for final visual outcome. And also the Harbor analysis validated this as well, where you saw at month 12 almost a 3-letter differential in those who had persistent intraretinal fluid. And on the right side, you see the month 24 results showing you, again, about a 4 to 5-letter differential in those patients who had persistent or residual intraretinal fluid despite good treatment over time. So the takeaways from this really are that intraretinal fluid matters. And again, we saw from that Harbor post-hoc analysis that those patients who had a definite detriment with regards to intraretinal fluid. And here in this slide, they actually grade them by mild, moderate, or even severe intraretinal fluid, and found a nice correlation between those who had mild or moderate disease had a better, obviously, activity and better outcomes versus those who had severe amounts of intraretinal fluid had worse visual acuity at the end of these studies. Now, if you want to look at the initial OCT and say to yourself, of all of these parameters we have, what can determine the best corrected acuity at 12 months? So if you're sitting in front of the patient, like I just showed you, and trying to figure out what the prognostic factor might be, here are all those factors ranked for you in rank order. And what you can see essentially is that at baseline, the presence of intraretinal fluid at the center of the macula is an important predictor of best corrected acuity at 12 months. However, once treatment has been initiated, it really falls more upon the best corrected acuity. So at 3 months and beyond, that's what we look at to determine the final visual outcome. But yet, in the initial stages, it's important to dry the retina as fast as possible and to get the best possible result from that. Let's switch gears a little bit and talk about subretinal fluid. And this is just a slide showing you the presence of subretinal fluid. It's an early sign of exudative disease in active type 1 lesions. It's potentially protective, and what we found essentially in many of these randomized trials is actually patients had a better visual outcome when they had some persistence of subretinal fluid despite continued therapy over time. And here's just that result showing you again in the VIEW study. We're looking at both subretinal fluid. When you have foveal subretinal fluid, you had a slightly better improvement in visual acuity than those patients who did not. You can see that almost at week 52 at almost an 8-letter differential. So if you had subretinal fluid, it was a better prognosticator for final visual outcome. And this was in CAT, again, validating once more that there was almost a 7-letter differential in those who had persistent subretinal fluid versus those who did not. So this again goes to the fact that we talked about maybe a protective effect on the RPE with the subretinal fluid. And finally, you have this same graph in the Harbor analysis showing you of a mean differential about 2 to 3 letters at month 12 and month 24, again showing you that there's a better improvement in visual acuity in those who had persistent subretinal fluid over time. So looking at these sort of together, we have to look at, why patients might lose vision over the long term. And one of the big things that we've learned is that patients might develop macular atrophy. And macular atrophy or geographic atrophy can occur in the setting of neovascular AMD. And what you can see essentially in this slide from the CAT trial was that those who had no subretinal fluid had a much, much higher proportion of geographic atrophy in the comparison to those who did have subretinal fluid. So this goes back to the point which I made before, which is that these studies have shown us that subretinal fluid has a better prognosticator from a visual outcome standpoint, but also might have a better outcome with regards to preventing geographic atrophy or macular atrophy from forming in this condition. Let's finally look at one last compartment, which is a sub-RPE fluid compartment. And this is one we have really no understanding or role about what changes here. This is the pigment epithelial detachment. And while we think that it's a link to poor visual outcomes and when it's correlated with both IRF and SRF, alone we don't really know what the prognosis is for visual acuity. And so this is maybe an area of burgeoning research, and we need to learn more about this compartment and what this might be, because I think this needs to be reappraised, especially in the OCT era over time where we can measure these more reliably. So just to summarize sort of the data from this talk and the case we discussed, the IRF or intraretinal fluid is associated with an unfavorable visual outcome in patients with neovascular AMD, but the presence of some residual subretinal fluid can be tolerated, and you can get good visual outcomes and a reduction in the amount of atrophy in those patients with persistent subretinal fluid. So let's switch gears again and talk about how we use practically this data I just showed you from these randomized clinical trials in practice to follow patients. And my big way I do this is using Retina Workplace. This is a product we've had from ZEISS for many years now. And what you can see in Retina Workplace, first and foremost, is you get this really clean, nice view of the B scans that are present in this patient. Here you can see the B scan that was done in October, November, and February. And these are registered B scans, meaning that if I move the cursor, and I'll show you that in a moment, anywhere in one of these screens on the top, it automatically registers and shows me this patient's progression over time. So you can see in October, the patient had an area of pigment epithelial detachment. November was actually the time when I saw this patient in clinic and realized they had some component of subretinal fluid. I owed this to the conversion to neovascular AMD. I have a fluorescein that showed that as well, which I'll show you in a moment. And then lastly, after treatment in November, now in February, you see a reduction in that subretinal fluid component on the raster scan here as well. On the bottom, you're presented with a lot of great data information, and this is one I use for both diabetics and neovascular AMD patients, because it shows you a graph of both the central subfield thickness. It can show you cube average thickness, cube volume, shows you lots of different components, and maps it out in a graph over time and looks at the last 6, 12, 24, whatever you set the machine to do, it will essentially look back and do for you. And it's the way I've been able to hasten my decision-making in clinic, but make really informed decisions because I can follow this fluid over time using Retina Workplace. Here, for example, is another slide showing you again those analytics that are present. So I can look at cube volume, cube average thickness, volume under the ETDRS, and average thickness under the ETDRS scans as well. And why this is important, especially when you go think about your diabetic populations, is you're trying to achieve a dry retina, but yet you know that totally dry retina is not always necessary in those populations. So you can try to look at the cutoff of 320 or below, rather than maybe looking at the morphology to see what the OCT shows your diabetic populations. But here you can see quite nicely that there is a very, very nice improvement in the central subfield thickness, which is, again, owing to the fact that there is an improvement here. And by the way, if the boundary lines are drawn inappropriately, you're able to really fix them right away in Retina Workplace, which I find is very valuable when SD-OCT hasn't mapped this PED properly. So that's also another technique I use to do that sort of thing. Here's another picture just showing you can get enlarged high-definition raster scans as well, and that can be very helpful to follow the patient over time. And this is another sort of area which I think is really great, and this is one that I can show you here that I use a lot, which is both looking at the RP elevation, so the elevation of the RP on a heat map, which you can see in the lower left corner for all of these dates. And you can see that the RP elevation didn't change very much, which is obvious from the scans, the line scans, but this shows you really a nice heat map that it hasn't, because it's now segmenting that RP elevation very, very nicely for you, so you can see it separately to that. But look at the other sort of areas. You can actually look at the VRI, the mid-retina, the ellipsoid zone, the choroid, and actually you can do a sub-RPE slab to look for geographic atrophy as well. So if I'm looking for patients in clinic who have sudden vision loss in the setting of neovascular AMD, and if I don't see much of a change in their OCT, I'm going to the sub-RPE slab to see if there's more subillumination and therefore maybe more macular atrophy or geographic atrophy in response to the anti-VEGF therapy we're sort of administering. Here's another video. I'm just going to play this video for you to show you what it looks like. But essentially what you can do is register. Again, I showed you how these scans are registered. And if I scroll over, I can follow that area. So you can look at all parts of the cube. So if you had a lesion that might have been not necessarily in your photographer's view, or you wanted to look at the corner there, you can look at that as well and determine that very nicely and very easily. So you can move this around very well. It gives you active measurements as you do this over time. This is another video just to show you again some of the benefits of this in a different way. So there also is the ability to look back at the fluoresceins and to automatically arrange them for you. So this is called the Retina Overview and of the right eye. And here you can see it's showing you the color image, a red-free image, the earlies and the lates. It's able to pick up the actual timings on the actual fluorescein and automatically puts them in front of you in the way you'd expect it to look like. Here you can see that that's obviously a fluorescein positive leakage point here, and that was when we had that patient who had that component, and we noticed that conversion. So that's why we initiated therapy in that patient through this analysis. So just to give you some of the future steps, we're working on a deep learning neural network platform for OCT in collaboration with ZEISS. We are grading OCTs with them and also testing the algorithm in various disease states. And what we're at right now is this level of what we call the crawl, walk, and run approach. We're at the crawl approach where now it can determine whether you have intraretinal fluid, disruption of the vitreoretinal interface, subretinal fluid, ellipsoid zone disruption, RP atrophy, RP elevation, or even drill. And what we're doing now is based upon that, we're developing some algorithms for decision pathways so that the clinician or the optometrist or even maybe a technician will know what to do with the urgency of this. And eventually it will then give back a diagnosis of any of these disease states we have, but that's something we're teaching the model to learn over time. So this will hopefully come in a newest version of the ZEISS software. We're working actively to get this out to users because it can be very helpful. You know, if you're not familiar with an OCT, or you might have seen a B scan, and B scans are becoming far more dense these days with far more line scans, it's possible you might have missed this area or small area of fluid or a small macular hole, for example. So this can be very, very helpful, and this is the sort of work we're doing right now with ZEISS in California to validate this in a larger scale model. Here's to show you some of the output there, where you can see on the left side of the screen on the actual en-face image where it's actually labeled those portions of the eye which have the abnormal VRI interface, and again showing you on this image here where that VRI interface difference is as well. So it's easy, it's sort of like paint by number sort of thing where people can look at it and immediately tell what's happening, and as a result probably will hasten their ability to make good informed clinical decisions, hopefully. So just to summarize, the presence of fluid has differential outcomes in patients with neovascular AMD. The outcomes depends on your ability to rapidly interpret the data and to make informed decisions for the patient. And I have found, at least in my practice at ZEISS Retina Workplace, has been a key way that I've been able to find these abnormalities and make more reliable and sound clinical decisions in a rapid-paced clinic, and assure myself the best possible outcome for my patients as a result. Thank you.
So, Rishi, thank you. Great presentation. We got a couple questions here that we'll ask. One I have actually for Carolyn is, do you at your place, are you guys looking so much at the subretinal versus sub-RPE versus intraretinal fluid and categorizing them all differently?
Well, I think that we're definitely categorizing intraretinal and subretinal fluid differently because that's a little bit easier to even tell just from looking. But I love the way that you looked at the sub-RPE fluid, Rishi, and I think that was great. And the one thing I really like about the way that you demonstrated in your talk, like with workplace, is that you can see the changes over time, because it's really easy to miss those small little, subretinal thinnings or a very, very small developing macular hole. And I like looking at the en face and seeing how you can see the changes over time.
Yeah, I think we've learned from all of these studies that I just presented how little or a lot this really matters. And I think that we look at these OCTs day in and day out, and if you ask a lot of retina specialists, some look at the cube, some look at the raster scans, some look at just the maps. And so you try to present the most coherent way of looking at these. I think ultimately the software will develop and go into the format it is in now, probably further, where it actually measures those volumes for you, because I think that's what we want to get out of this is, ultimately, if the machine spit out IRF is now 0 and SRF is present, we probably could be better even about decision making we even can do now. So it doesn't do that now, but I think in the near term future, with further development of the algorithm, working on other things, it is definitely a possibility.
So for both, here's a question.
When I look at patients, I look at the
Go ahead, Caroline. I'm sorry.
Okay, no, I was just going to say, when I look at pictures on patients, I look at the volume, the cube, I look at the one line, I move the line to where I want it to be, and it can take a little bit of time. So if I had a machine that was looking at multiple things at the same time to do that more quickly for me, I'd be very happy. Or an algorithm. Okay.
All right, so Dr. Eichenbaum says he has the question. If you're tolerating subretinal fluid in the trenches, when is enough enough? It gets subjective in real life as opposed to the fluid study. Is there a good real world guidance you can give?
Yeah, it's a great question. You know, this fluid study was interesting. I omitted that one. It's a little bit of a contentious study, but basically they omitted 200 microns of fluid in that study. So just imagine the entire slab or the retinal thickness was omitted. They just essentially treated till the intraretinal fluid was dry and then allowed for patients to have that kind of subretinal fluid. And they said they found no specific outcomes at 1 year, albeit that the number of patients are pretty small and the visual acuity gains weren't that great in the study either. So I would say the answer is somewhere in the range of less than 200, but not zero, is the tolerance level. And I think we make more of subretinal fluid than it needs to be. I think we think of it as the hallmark of exudative AMD, but in reality, it may not be that way. And so it's probably someplace in between that, though the evidence is not great. All we know really, I would say, is that the IRF should be dried up as much as possible. And we really want to try to address that as much as we can. And vis-a-vis, I'm not saying we tolerate SRF, but I think we will certainly keep injecting until IRF is gone and then leave maybe some subretinal fluid behind, if that makes sense.
Here's what I want to get both your answers on. It's from Leonardo Diaz. Do you change between PRN and treat and extend based upon fluid if it's intraretinal or subretinal?
So I typically am more of a treat and extender than a PRN person. I take a lot of patient factors into account, but I will treat aggressively till the intraretinal fluid is gone. I like to think of subretinal fluid. Sometimes subretinal fluid, it just might not be active. It might be stable. It might take a little longer to go away. So I think that might be why it has less of an effect on vision. But I treat intraretinal fluid aggressively. Rishi,
Yeah,
what do you do?
I do the same, and I follow the graphs. And I think it's important to follow the graphs because they help you determine the CST, which essentially is a measurement of both IRF and a slight component of SRF too, because you're essentially going from the inner border of the retina down to the RPE layer, essentially, in the algorithm of the software. And so that's a really easy way of following it rapidly rather than kind of consuming ourselves with looking at these individual compartments per se. The other thing I'll tell you is there's been a lot more studies on the OCT variability, right? How much does your OCT change from the time that they're getting active until the time they're getting inactive? Is that, is that sinusoidal wave 20 microns, 30 microns, 100 microns? Because that in itself is a marker of bad activity. And I think we're going to find, I'll predict a year from now, maybe we have a way of looking at that and saying, okay, 100 microns of fluid means that you really should have cut your interval down and treat and extend. And we're looking at this in a very different fashion right now, where we're looking at IRF and SRF components, yet we don't have any really good way of measuring that. Maybe CST variability is a much better way of doing that altogether.
Sure. Combine a couple of questions here from Monique Camacho, which coming all the way from South Africa is impressive this hour and night, and a few others. So the question here is the presence of subretinal fluid still considered protective amongst the community, or is there still a debate on that?
Well, I think we don't know. In some cases, it might be protective of geographic atrophy, but I typically treat it. And I try to get rid of as much fluid as I can. Sometimes even with treatment every 4 weeks, patients will have persistent subretinal fluid, and then I'll try to extend them out to treat them less frequently. And as long as that doesn't change or it stays relatively stable, I'll continue along that path. But I think we just don't know yet.
Sure. And so Dr. Singh, do you think some of the fluid can help reduce the risk of GA with overtreatments?
I don't think it reduces the risk. I think that's where people are misinterpreting it. I think it actually, what it's doing is it's almost like a veil. And the SRF is turbid, or it's not as clean as we would want it to be from a fluid perspective. And really it's masking atrophy. And while we think that the patients have, less atrophy. It's really just that they have this veil of subretinal fluid present there. Now, ultimately, the visual acuity doesn't match up with that argument, because you saw from the studies I showed you that the SRF actually, the presence of it had a better visual acuity outcome. Maybe there's something about the biology and the photoreceptors that SRF is somewhat protective of the photoreceptors versus being gone and then having the loss of those photoreceptors and that flattening of the retina against the RPE with loss of photoreceptors. Maybe that's there, but I don't think it's truly that the SRF is protective. I think it's protecting the photoreceptors to some level. It's blocking them from looking at the general atrophy, but ultimately, I'm not sure if that's really the case in that situation.
I'm going to summarize the next question here, then we'll go to the next presentation. But from Jim Suki, excellent presentations, but he wants to know subretinal fluid versus the vision. How are you taking into account the vision before you treat, or are you treating regardless of fluid or not?
I'll let you answer, Carolyn. What do you think?
Well, vision is always important. I think that definitely, we like to have vision as a guideline because that's what all of our studies are based on. But in clinical practice, we probably rely more on OCT when we do our treatment. And there's lots of reasons for that. I mean, patients come in and we don't always refract them or get their best vision the same way that we do in the studies. So I certainly use vision as a guide. Plus minus a line is usually within maybe the variability that people have. And patients often have more variations in their vision when they have AMD. Probably realistically, I use OCT as more of a guide though, when I'm treating people real time.
Yeah, I agree with Carolyn's comment. I mean, I think if we had better ways of assessing visual acuity other than subjective Snellen charting, and even ETDRS is good, but it requires a lot of intervention. I mean, there's lots of apps that have been developed like My Vision Tracking and all these sort of other studies that have been done on these sort of other, hyper acuity stuff that's embedded in the Natal 4C Home study, for example. Like there's lots of different things out there. Those are probably much better functional measures of visual acuity than we have. So what do? Because we don't have those functional measures right now. We rely on OCT, which is reasonable. I think at better visual acuity levels, the OCT has become so discordant with those visual acuity levels that it's not a very good marker. And so we have to look at treating the patient at that point, right? So if patient's 20/20 and they have a little bit of subretinal fluid, a little bit of IRF, we're going to keep extending them and keep treating them. But I'm not going to be as aggressive as that patient who might be 2100, who's teetering on the level of legal blindness and the OCT still has fluid on it. I'm going to be more aggressive with that 2100 patient than the 2025 or 2020 patient, I think. So that's natural, I think, based upon what we do. We don't want to obviously over-treat these patients as well.
Great. Well, without that, I'm going to switch over to Carolyn here. So I'm going to mute myself and turn my mic off here. But Carolyn, thank you, and take it away here.
It is a privilege to be here today to discuss retinal imaging with OCT angiography. So, in brief, what is OCT angiography? It is a novel imaging modality that visualizes flow in the microvasculature by detecting motion contrast from moving red blood cells. It provides three-dimensional images of the retina, choriocapillaris, and choroidal vasculature. There's no dye injection, so it's faster than dye-based fluorescein or ICG angiography, and it's also repeatable at every visit. The images are sharp and not obscured by dye leakage. Compared to structural OCT, it is a little bit slower imaging, and high-speed instruments are required for OCT angiography. Very slow flows may not be detected. It cannot assess vascular permeability, and there can be artifacts with OCT imaging, so images require careful interpretation. So B scans are acquired multiple times from the same location, and decorrelation or changes between B scan show moving red blood cells, and scans are repeated at different positions to generate the OCTA volume as below. So with OCT angiography, there's some terminology that it's important to be familiar with. B-scan is referring to the cross-sectional OCT image that we're used to see. Another term for this is structural OCT. C-scan refers to images parallel to the retina surface, and this is also known as en face images. Segmentation refers to separation of the retina into different en face layers, where a slab is a thick tissue section and a slice is a thin tissue section, and registration refers to correlation of the B-scan with the C-scan. So here's an example of OCTA segmentation in a normal eye. At the top is the superficial retina plexus, and if you look at the structural OCT, you can see there's a red line and a green line showing the segmentation that corresponds to the OCTA image that is adjacent to it. So this is the superficial retina plexus segmentation. Below that is the deep retinal plexus segmentation. We can see here the segmentation lines and the corresponding OCTA image. This is important. This is the outer retinal segmentation between these two lines, and the OCTA image is black because normally there is no blood vessel flow in this segmentation. And just below that is the choriocapillaris segmentation. OCTA does have some artifacts that are associated with it, and because the imaging depends on motion of red blood cells, any external motion of the patient or even ocular saccades can produce motion artifacts. There's other artifacts, and it's just important to be familiar of these so these artifacts aren't interpreted as pathology. The other artifacts include media opacities, projection artifacts, segmentation errors, vessel visualization artifacts, and size artifacts. And poor signal strength will increase artifacts and reduce reliability. So the unique thing about OCTA is that now we have correlation of structure from structural OCT and flow. And for example, here's a case of a patient with a history of central serous retinopathy and what appears to be a small PED on examination. And here's the corresponding fluorescein angiogram. And is that definitive of choroidal neovascularization? Here's the structural OCT, and we can see that there's a very flat fibrovascular PED here. And let's look at the OCTA. Well, on OCTA imaging, at the en face image through the choriocapillaris, we can see that there's definite choroidal neovascularization. And here's a unique feature of OCTA imaging that we can do something called flow overlay, where the region of flow on OCTA is superimposed onto the structural OCT, where red represents flow. And we can see that there's flow in that fibrovascular PED, confirming the choroidal neovascularization. So let's go through some cases. And these are cases that I chose from my clinic where I felt that OCTA helped me understand the patient's pathology or helped me with management. Here's case number 1. This is a 37-year-old female who presented when she was 35 weeks pregnant. She was referred for a macular lesion. She's minus 15 diopters of myopia. She deferred fluorescein angiography, which is preferable in someone who is pregnant, and she had no symptoms. So we can see on the color fundus photograph, there's this white-gray lesion just infratemporal to the fovea, and that corresponded to this elevation on the structural OCT. So here's the OCT angiogram in this lady, and we can see that this area of elevation corresponds to choroidal neovascularization, seen here. And this is a segmentation in the avascular layer, and one might say, why are there blood vessels there? Well, this is an artifact called projection artifact, where we're able to see blood vessels from a more superficial layer projecting onto a deeper layer. but we're still able to identify the pathology, and the structural OCT below with flow overlay confirms that there's flow in this region. Upon taking the history, she also had a history of photodynamic therapy that was done in 2004. So OCT angiography confirmed that she had myopic choroidal neovascularization, but this was not leaking, and observation was the management at this time. Here's another case. This is a patient who had a history of exudative choroidal neovascularization in her left eye, and her left eye had been treated with anti-VEGF therapy. And I just wanted to show you her right eye, because if we look at the color fundus photograph, it looks like she has intermediate macular degeneration. She has some small drusen. She has some pigmentation changes. There's no sign of hemorrhage or exudate. When we look at the structural OCT, she has a very small fibrovascular PED. Here's the OCTA, and we're able to see that she has choroidal neovascularization actually in this region. So she has non-exudative choroidal neovascularization in her right eye. And I think it's useful to know this because I like to follow these patients more closely and be on high alert because they might convert to exudative choroidal neovascularization. Here's another case that I wanted to show you. And this case was interesting because it stumped some of our fellows. This was a patient who was referred for a superior scotoma and blurred vision. The acuity measured 20/40 in the left eye, and the patient was initially diagnosed with having a branch retinal vein occlusion. And if we look at this color fundus photo, and this is the Claris instrument that did this fundus photo, we can see that there are some features that we would see in branch retinal vein occlusion. There's hemorrhages that are flame-shaped, and also intraretinal hemorrhages along the infratemporal arcade. There's some cotton wool spots inferior to the optic nerve. We can see some sclerotic veins here, here, and as well as here along the infratemporal arcade. But there are a couple atypical features, and one is that the hemorrhages extend above the horizontal raphe. There are some irregular loopy blood vessels here, and there's also AV nicking superior to the optic nerve. So is this consistent with a branch retinal vein occlusion? Here is the Claris fundus photo montage, which places multiple images together to get a wide field view. So here's the OCT angiography. This is the 12 by 12 millimeter view with the angioplex looking at the superficial segmentation. And we can see that there are these large areas of capillary non-perfusion with no flow. But there's also a region up here superior to the optic nerve. And we can see that there's flow in these irregular vessels here. Let's look at a different segmentation. This is a 15 by 9 millimeter view of the deep segmentation. And now we can see on the OCTA here that there are these small dark black spots that are also in the en face deep segmentation, and these are from retinal cysts. So this patient had radiation retinopathy, and that's why these features are atypical, not just from the branch retinal vein occlusion, but this is radiation retinopathy producing these changes. And we can see here on the structural OCT that there's also a little cystic area there. So here's another use that I found for OCT angiography, and that is evaluating my patients with very severe non-proliferative diabetic retinopathy and proliferative diabetic retinopathy. So the OCTA machine can take multiple images and mosaic these together. And this is an example with the Plex where there are multiple 12 by 12 OCTA images that are mosaicked to form this one image. And this is a patient with diabetic retinopathy, and we can see that there's a lot of peripheral capillary non-perfusion, and there's these irregular areas of flow. Here's another region, and even supranasal, we can see that. So we had a project, and this was published in Retina last year, to look at these irregular vessels and evaluate them with flow overlay to assess whether they represented retinal neovascularization or IRMA. And this is an important thing to know for our treatment paradigm, because when patients have retinal neovascularization, they have proliferative diabetic retinopathy and treatment is indicated, versus IRMA, which may represent severe non-proliferative diabetic retinopathy. And in those cases, there may be times when observation is indicated, and there may be instances where treatment is indicated. So it's a really important step to know in patients' medical evaluation. So in order for us to distinguish retinal neovascularization from IRMA, what we did was we identified areas of irregular vessels, and you can see that we evaluated each area separately, and we looked at the structural OCT in that region with the flow overlay. And as I said before, the flow overlay is the sum of the raw decorrelation signals from the OCTA placed onto the structural OCT. So red indicates flow. So if we look at this area of abnormal blood vessels here, we can see that there's flow on the surface of the retina that has extended above the internal limiting membrane. And this represents neovascularization of the retina. Let me show you some examples. Here's a region within this yellow box that we identified with OCTA as irregular flow. And then here's the corresponding fluorescein angiogram on the right. We see that there's no obvious leakage. And if we look at the OCTA in the same area, we see that the flow is intraretinal. It has not extended onto the surface of the retina. So this is consistent with IRMA. IRMA shows intraretinal flow. It's often core-like. There might be some outpouching of the ILM, but it does not breach the ILM. And we found that there can be adjacent regions of capillary non-perfusion. Here's some examples of retinal neovascularization. We can see on the right, there's an area in the yellow squares and an area in the blue squares. We can see the OCTA shows the irregular vessels. The flow overlay just below it shows that there's supraretinal flow that has breached the ILM. And you can also see it here on the posterior hyaloid and these much wider cores. And this is consistent with neovascularization of the retina and confirmed with fluorescein angiography. One region is if there is fibrosis associated with retinal neovascularization, as in these color fundus photographs on the left, we can see that on the flow overlay, the flow is less obvious on the surface of the retina, likely related to the fibrosis. Here's my last case to show you today. This is another patient who came in, and there was a suspicious area identified. We can see the Claris montage on the left and an area of abnormal flow here. I zoom that up here. And here's the 12 by 12 OCTA showing that this patient had retinal neovascularization with adjacent areas of capillary non-perfusion. And sometimes I don't do a mosaic. I just look at a few separate areas to see that the findings are consistent. And this patient had peripheral areas of non-perfusion, multiple areas of abnormal blood vessels in this patient who had proliferative diabetic retinopathy. And we can see here on the flow overlay that this patient had areas of flow that were above the internal limiting membrane, consistent with neovascularization of the retina. So in summary, I hope I've shown you that OCTA can help improve our interpretation of structural OCT by providing complete blood flow information. It helps to better delineate pathology. It can identify choroidal neovascularization and retinal neovascularization, which are both very important in our treatment paradigms. It can help to distinguish retinal neovascularization from IRMA without fluorescein angiography, and in some cases, it may be able to replace fluorescein angiography. Thank you for your time today.
Excellent presentation, Carolyn. Thank you. We've got a couple of questions for you here as well. So let's go with the first one here. And the first one's actually a question I have for the two of you. We had that case of non-exudative AMD in the fellow eye that had exudative AMD. In today's environment with COVID-19 and getting access to patients, do you find yourselves treating those patients earlier or maybe before this fluid, or are you keeping the same model going?
Kevin, I'm keeping the same model going, and that's because I think that we still don't understand how anti-VEGFs affect choroidal neovascularization in the way that, for example, if a patient has exudative macular degeneration and we treat them with an anti-VEGF, usually the fluid will go away, but we can still see the choroidal neovascularization on OCTA. So it doesn't necessarily make that lesion go away. And I think in many ways, choroidal neovascularization is a response that happens in people with age related to either factors that are released or related to ischemia, and they develop choroidal neovascularization. It might not be a bad thing. It's bad when it exudes, when it releases fluid or exudate or bleeds. So I haven't changed the way that I do things yet, but I really do monitor patients much more closely if I find that they have unsuspected choroidal neovascularization in an eye that looks clinically dry. Because there would be no endpoint. If I treated them with anti-VEGFs and the choroidal neovascularization was still there, what would my endpoint be?
Yeah, same for me, Kevin. I think that there has been two really good studies. The PROCON study was one of the studies that was done looking at this sort of, what do you do with patients potentially to prevent them from developing neovascularization? Obviously, in patients who have fellow eyes who have this, and they didn't find any benefit of giving a aflibercept every quarter in those patients who have it. Now, granted, those patients do not always have type 0 sort of lesions, those quiescent double layer sign OCT kind of images. But yet the study didn't show it, and unfortunately, you have to really inject a lot of people to get a very little benefit there. So we have I mean, the beauty of what we have right now is there are still some technologies available to us. Amsler grids, the 4C home test. Those devices are out there and available, and so we can still use them to monitor the patients, albeit not as perfect as a home OCT, which should be coming hopefully soon from a lot of different manufacturers. But that would be ultimately, I think, where we want to be in the field. But right now, we still have some pretty good tests that I think are very good at determining metamorphopsia changes that could be indicative of the conversion. All
right. How would this is from Amy Goldstein, I think, on the West Coast there. How would your treatments differ in diabetic patients with only IRMA versus retinal neovascularization?
Well, when I see retinal neovascularization, I treat with, usually it depends, of course, on patient factors, but I usually use combination of panretinal photocoagulation and anti-VEGF injection, starting, for example, if they have DME, I would start with an anti-VEGF until the DME component was gone, and then maybe try to add some PRP also, because I do find a lot of my patients are not very tolerant of frequent injections. And then if a patient has IRMA and they don't have retinal neovascularization, I will watch them very closely, but occasionally I will treat them if they had, for example, vision loss in their other eye, or if they're a non-compliant patient, or, you know, there are certain things that will put me over that kind of edge. If they live in a remote scenario, or if they're poorly controlled diabetic. All these things will affect what I do.
Yeah, I love your methodology, Carolyn. It's really great to hear that. I guess I take a little bit more of a straightforward approach with these things because I just like you said, like if the patient doesn't follow up or if there's an issue, and it's like they're almost what I term sometimes half pregnant. Essentially, they're going to develop the disease over time, and it's just a matter of time, right? So why wait it out, and why not start and discuss the idea of even light PRP in those cases? And they do really well. I mean, I think that's one of the things that I think we've learned a lot from wide field angiography is that, you know, IRMA might look like IRMA to you and I, but then when you look at the far periphery, there's some neovascular tufts we might have missed and not seen necessarily with 7-field standard imaging. So I just kind of like pretty much at that level, if there's the level of IRMA, NVE, or NVD, I'm not measuring as much as, and I love the methodology. I think it's obviously evidence-based, but the problem is that the patients aren't necessarily always evidence-based and they always sort of do their own thing. And I think the one study I can leave you with that made a lasting impression on me about this was, there was a study that we did at our own institution that looked at a delay in treatment of PDR by a month and what effect that had on the patient. And what it actually led to was after a year was almost a 10-letter differential in their final visual acuity if they delayed that PRP by a month. And so I guess I'm a little bit more aggressive with the PDR patients just because I think we have a little bit more looser control in maybe my neck of the woods in Ohio. And that's just my difference in methodology, but I love the way you think about that.
Well, you know what, Rishi, I'll tell you right now with everything that's going on in the world, I mean, I think that I'd be much more easy to, you know, to treat someone when I see them because it's very hard to get patients back in. But I feel usually I feel like there is time till we get these people in for treatment. But
So a question here from Dr. Eichenbaum is, will SSOCT change your practicality of usage of OCTA?
will SSOCT, sorry, what was that, Kevin?
Is SSOCT changing your utility of OCTA? Swept source OCT.
Well, I think the real benefit that I notice is that the wide field view that we have of OCT that we can get with the Plex Elite, and I really do find that I do the 12x12 mosaic in almost all of my diabetics and anyone with peripheral pathology, and I think it's great. I think it's fast, and I think that there'll be utility to look at choroidal neovascularization as well.
And we have one here from Dr. Chaudhry. Where is it? I had it here a second ago. Let's see here. Have you seen any data, personal anecdotes on biomarkers for CNV reactivation in OCTA?
Well, I like to put it together looking at the OCTA as well as with the spectral, with the structural OCT. I think that's very helpful to look at reactivation. But what I've noticed in my patients is that the CNV on OCTA seems to become more dense, the vessels, and there's more terminal bulbs. And then sometimes another thing that we see is the kind of the dark halo around CNV, all signs of activity.
Yeah, actually, we had a study that we published with OCTA that we looked at that dark halo effect. And that dark halo effect means a very high frequency of retreatment with anti-VEGF. You know, less than 4 weeks or 6 weeks at most. And most of those patients with the dark halo were those who actually could be extended 10, 12, 14 weeks and further. So there was a very big differential in those dark halos. So that's a reason to get an OCTA for me a lot of times on the initial examination. And the nicety now with Retina Workplaces, I can put it up and follow it now. I can do it while alongside my OCT and look at it across the board at all those sort of intervals. I showed you the macular thickness maps, but you can actually look at the OCTA as well.
Great.
And it's the one way I've been able to really finally grasp the value of OCTA because it was just so hard to review. And I struggled to really get the review software running and working. And slabs weren't proper. Now I can look at it all myself, which is fantastic.
So I want to thank you guys for this. We do have, at the end of this is a quick survey for anybody that has taken this when they close out of it. It will take you to a page that actually has a place to give us recommendations on what you want to hear in future webinars. And it will also have a page that'll bring you there if you're looking for breath shields for your slit lamps and things like this that are being provided to people out there in the field to try and keep you guys safe while seeing your customers and other COVID-19 responses from us. So thank you for your time. Thank you for the audience for participating, and I hope you guys have a safe rest of your evening.
Thanks,
You
everyone.
will.
Stay safe.
See you soon.